This is the presentation of a gentleman who came to me complaining of bilateral arm pain, specifically in the distal arm and the proximal forearm on the anterior side, so close to the front of the elbow. This gentleman sat at a desk about 10 hours a day working from home. He also did light workouts several days a week, which factors into when he would feel some symptoms. He had had symptoms about 6 months prior to meeting me that got better almost 100% on their own. It presented first in the right upper extremity and then in the left. But then 6 weeks prior to meeting me, he had noticed the pain come back with pull-ups. And he noted that he didn't feel weak, he just felt the pain. He attributes the likely cause to keyboard ergonomics. I don't think he was entirely sure. Symptoms were intermittent. They could be worse with lifting something like a bucket that was 20 pounds or loaded elbow flexion exercises. But importantly, he also said that long days at the desk could make his symptoms come about. He felt better with rest. He didn't notice that he was stiff at all in his elbows. He would not disturb his sleep. And so his verbal history, because of the fact that it's bilateral, because of the fact that it was atraumatic in origin, and because of the fact that it can get worse with sitting for long periods of time, it made me think there was a higher likelihood that this was a spinal problem versus each elbow or versus two separate entities. So in terms of his movement exam, this was over telehealth, so I couldn't passively test movements or aggressively test manual muscle testing. But looking at the neck, I said that he had nil loss in every plane of motion except for extension. I noted he had a minimal loss of cervical extension, and what he perceived was that it felt stiff going into extension. In terms of producing his upper extremity pain, we could use a weight to produce that pain with doing a biceps curl. We explored cervical retraction and extension, and I went to overpressure quickly. And then the baseline test we used was doing that biceps curl. And so after we did a few sets of that, and I compared it to prone doing it sustained, which didn't seem better. After doing a few sets of seated retraction extension with overpressure over the chair, the biceps curls were 10 to 20% better, which is not enormous, but it was enough for me to take it and run with it as a repeated movement exam, testing over several days at home. And we of course spoke a lot about posture, since he was already clued into ergonomics, and because again he noted pain could present in both anterior arms and forearms with a long day at work. So his homework was to do about 10 every few hours. I saw him again about a week later. He noted that he had to carry luggage, and that was better. He went rock climbing, and that was better. So things that would load the elbow into flexion were better. His movement exam was that he felt that his cervical extension was better, and I objectively noticed that it seemed better. It's somewhat subjective, but it seemed like he had more extension, so that's important. The biceps curl testing was about 75% better, right and left. We reviewed his home exercise program, and his demonstration of it was good. We talked a lot about posture again, and then I added a little bit more force by having him hold the last rep for 10 to 20 seconds. So changing the home exercise program only in that we added a little bit more time as a parameter for adding more force. I wanted him to test pull-ups before we spoke again, because in the past that was aggravating as part of his workout. So we didn't change too much. It seemed like we were on the right track. At least it seemed like we had the right source of the problem and hopefully the right exercise. I did not see this gentleman again. We communicated via email, and he noted that he had his symptoms under control. He did not do the exercises religiously, but he felt that if he did do them more consistently, he would probably have 100% resolution, but his resolution was enough to make him satisfied with the care. He could work out without pain, and we talked about the changes to his home office, and he was able to do those to the extent that these symptoms no longer bothered him. So this case kind of points out that people and clinicians jump to muscles and tendons and problems in the extremities that can easily be from the spine, and secondly, can easily be remedied with the right directional preference. So his directional preference was retraction extension, and we went straight to overpressure because he wasn't irritable, and because he's a strong, healthy individual. I wanted to get to overpressure quickly. His case highlights that the spinal component can be fixed quickly if you have the right directional preference, and we should always explore the spine with extremity symptoms, either through the full repeated movement testing part of the exam, or at least explore the spine when you're asking specific questions in the verbal history and looking at baselines. And I will go back to the point that all motion looked good except for extension. And if you ask me how many degrees of extension would I consider normal, I can't give you a great answer. And part of it is experience and doing this for many years and coming to anticipate how much extension someone should have. Flexion is kind of easy. I want the chin to reach the sternum. Rotation is I want to be able to look over the shoulder, and side bending, at least halfway to the shoulder. Extension is a bit more ambiguous, and I understand that. But even if you don't have a number of degrees in mind or something that you're looking for in mind, you have to go by change. Because if a person gains range of motion or loses range of motion, then you can start thinking differently about how much their baseline was. So especially if you gain range of motion, then you've proven that the initial baseline testing of the range of motion was lacking. Conversely, if you lose range of motion, you don't really know much about the baseline, but you know that it's malleable. So if you don't know if someone's losing or has lost range of motion, is missing range of motion, then testing, if it makes it increase, will tell you at least that part of the exam was lacking to begin with. So the spine, even if it's a little bit of extension loss, I know a lot of people would not really correlate that with radiating or radicular or mechanical signs and symptoms into the extremities, but I find that quite commonly, that even a seemingly little or no loss of range of motion, because these losses of range of motion can be sometimes impossible to perceive, and they're just millimeters of how things are moving inside the spine at one vertebral level. Even these little losses of range of motion or disturbances in range of motion can affect the extremities.